Assalamu alaikum. Hello everyone. That is just a quick case of partial anomalous pulmonary venous return associated with a sinus venosus defect. And ASD and partial anomalous is a very frequent association. And there is a high frequency of being missed on cross-sectional imaging, especially when in the CTs or the presentations in the adult, and the focus is in a general hospital, and in many cases the cross-sectional imaging miss the finding of a partial anomalous or a sinus venosus defect. It is also frequently missed congenital anomaly, the partial anomalous venous stent, even in cardiac centers and reports by cardiologists or radiologists. So always screen for partial when there is a clinical request on pulmonary hypertension, dilatation of the right side, dilatation of the right ventricle, dilatation of the right atrium of unclear causes. Then always please check for ASDs and partial anomalous venous returns. Sometimes, or one of the causes, sometimes when they present later in life as an adult congenital heart defect, sometimes the focus would be on the manifestations or the complications of pulmonary hypertension. For example, in this case, we could see the mosaic appearance of the lung parenchyma, the severely dilated pulmonary artery, which is representing pulmonary hypertension. However, if we scroll carefully in the anatomy on the axial images, from cranial to caudal, we will see that the contrast is injected from the right side. That's why it's very bright on the right side. However, if we follow the segmental anatomy clearly, we could see that there is contrast here in this superior vena cava, and there is this vessel that is parallel to it on the other side, or kind of mirror image of it on the other side. Usually in normal anatomy, you will find a bridging vein connecting this side to this side. But in this case, we could see that there is a persistent left side superior vena cava. If we follow this left side superior vena cava, that will go down all the way along the left side of the mediastinum, and it drains to the coronary sinus, and from the coronary sinus it drains to the right atrium, which is ballooned or dilated. Also the coronary sinus is dilated, possibly because of the dilatation in the right atrium and the high pressure and volume in the right side at the moment. Again, if we scroll further down, we could see that is the supra-arch vessels, which is conventional branching. It is a left side aortic arch, and we have two superior vena cava. We have a dilated pulmonary artery, normal anatomical arrangement, so we could say it's not going to be a TGA because the pulmonary is on the left side, slightly anterior to the aorta, so we could say that this is going to be a normal anatomy. Scrolling further down, we could see the left coronary is a normal course and normal origin, similarly the right coronary, so it's a normal coronary origin. Scrolling further down, we could see that the right atrial appendage is very close to proximity to the sternum wires, dilated right side, so dilated right ventricle, dilated right atrium. But before going down, we could check the VA and AV concordance. So the right, we said that is going to be a normal concordance because of the arrangements of the pulmonary. The pulmonary is coming from the right ventricle, and the aorta is coming from the left ventricle, and we could see the mitral to the left ventricle, tricuspid to the from the displacement of the septal leaflet, we could tell that this is the tricuspid valve, and the tricuspid valve always follows the right ventricle, so it is AV and VA concordant. If we want to check the pulmonary veins, we could see on the left side, left lower pulmonary vein, and then we have the left upper pulmonary vein, both of them going back conventionally to the left atrium. If we follow the same on the right side, we could see the right lower, and there is an accessory lower draining to the left atrium. However, we could start seeing here a kind of a defect at that point between the right side superior vena cava, and the right side superior vena cava should only drain to the right atrium. However, on the way down, while it's draining again from cranial to caudal, while it's going down to the right atrium, it's draining one of the pulmonary vein, one of the tributaries, most likely the right upper, and at the level of the right middle pulmonary vein, we could see that it is communicating with the left atrium. So it's a sinus venosus defect. So CT could tell, and if I go further down just to check also for the situs, we could see that the liver is on the right side, dilated IVC collecting the hepatic veins. Still there is an infrahepatic IVC, so it's not interrupted. Stomach on the left side, so it's the situs solitus. Situs solitus, AV and V concordant, left side aortic arch. There have been no coarctation. We had a left side superior vena cava draining to the coronary sinus. It's a normal anatomical arrangement, anatomical relation, pulmonary artery to the aorta. So it's a case of a partial anomalous and superior sinus venosus defect. If it was from the inferior vena cava, then we will call it inferior type of sinus venosus defect, but this one is a superior type. So CT could diagnose or could achieve or could give the diagnosis, and also could detect for complications, for example pulmonary hypertension and the changes in the lungs. However, also a step further, the CT also could provide measurements whether that it would be suitable for percutaneous solution or that would be suitable only for surgical assessment, and that by providing certain measurements so that we can go beyond the limits, so we could provide also insight telling the interventions and the surgeon whether they would be able to close it surgically or percutaneously. So I'll just show some measurements that if we take on the CT, then it might help the clinical team in order to decide whether percutaneous or surgical solution for the closure of the sinus venosus defect. How is that by providing some measurements of the proximal and distal landing zones. So for example, that would be the superior vena cava, and we need to scroll above any partial anomalous, so always check that you are above the highest partial anomalous, which would be in this case that would be the level of the highest partial anomalous, so just above it, so we could measure the cross-sectional diameters of the superior vena cava at that level. If we say here, then we could measure the cross-sectional diameters, so that would be 10 by 11, and of course we need the distal landing zone, so that would give them also the measurements that they could tell yes or no, and if yes, what would be the size of the stent in order to close it percutaneously. So the proximal landing zone, we said it has to be just above the level of the highest partial anomalous. The distal landing zone is at the area where you could see all the lips or the margins of the superior vena cava junction with the right atrium, that if as soon as they close the defect, then they would have a space where they could put the new stent or the new or the closure of the defect. So we need to measure it, stay perpendicular to the margins in the two orthogonal views in order to get rounded margins of the distal, which is around 2.7. So proximal was around 10, and distally that's around 2.7 or 2.8, 2.9. Those measurements would allow the team, of course, to decide yes, feasible, and if yes, which type of stent that could cover this defect using a covered stent. But not only the measurements of the proximal and the diameter of the proximal and distal landing zone, what we need is also the distance between both of them. So we would need the distance from, that would be the point of the distal landing zone, and if you remember, that was the proximal landing zone, and if we need to check, that is around 2.8, which is good. Anything above the 4, that would be too high to close with any stents, so 2.8 distance we could see here from the distal landing zone upward just above, that would be around 2.8 or 2.9 centimeters, and that is a good distance, so that could be closed. In any case, if the surgical team decide, or that the intervention team decide this is not cannot be closed percutaneously, then at least we need to give them the height or the distance of that partial anomalous, which is usually at the level of the RPA, seems to be reroutable or close to the left atrium. If it's high above the right pulmonary artery, this means that it's too high even for surgical approach, and at that time we will need to measure the distance from that anomalous down to the level of the left atrium. So if we say that this is the level of the left atrium, right, so that would be the level of the left atrium again, so remember that is the left atrium, and if I go upwards again from the level of the partial anomalous down to the left atrium, then at least give them the measurements. So we could measure the proximal distal landing zones, and the distance between the proximal landing zone for percutaneous solution for putting a covered stent that would redirect the superior vena cava down again to the right atrium where it should be, and closes this communication. And if not, and it will go for surgical, then please measure the distance from the partial anomalous to the level of the left atrium for the surgeons to decide, yes, we can reroute it, or is it too high. Basically, you could take, yes, the level of the RPA as your landmark, or you could use the measurements from left atrium up to, I sometimes try to provide those images in order to give them a clear appearance of how it looks in space between the partial anomalous. Of course, you could do all your measurement and punch in order to remove unnecessary vessels, and then give the appearance in reality. And thank you.